Hi guys, welcome back to Module 4, Week 4 here at FNP Nursing 670. I'm so glad to get to work with you guys, and I'm excited to start on Renal Part 2 this week. Last week we did Renal Part 1, which included common urinary complaints, urinary tract disorders. We discussed chronic kidney disease in adults, hematuria, interstitial cystitis, proteinuria, and urinary incontinence. Hopefully you guys got to watch some of the YouTube videos I posted specifically about urinary incontinence and how to educate your patients on different exercises to help either reduce it or actually cause it to go away or help it to go away. This week's module includes prostate disorders. We're going to talk about penile and testicular disorders, as well as common endocrine and metabolic complaints, as well as BPH, epididymitis, hydrocele, prostatitis, and erectile dysfunction, and prostate massage. So again, last week, this is what we covered. Again, hopefully you guys are looking at those videos that I'm posting. They're actually great resources of just different avenues of information. I like to get videos of specialists talking about their specialty and what different things they're seeing currently in terms of their evidence-based practice. We will be reviewing the codes of the coding quiz. I will do a video on that just to go over all the answers to make sure you guys are really getting a solid understanding, most importantly, a conceptual foundation of how to just look at questions without even looking at that guide and just being able to kind of get a very broad understanding of, oh, that's low, moderate, or low, medium, or high acuity. So those are the kinds of things we're going to be talking about. Those, the likelihood is you will not see any coding specific questions on your boards. They may ask you what CPT coding is or something very generic, but actual coding, the likelihood is you will not see that on your boards at this point. But that being said, it doesn't take away from the significance and the importance of you learning it now, because again, you will be coding every single day with every single patient you see. That is your source of revenue for both your income and the company you're working for, the business you're working for. And remember, you're classifying patients either based on new patients or established patients. And the numbers in terms of new patients range from 99,201 to 99,205, with the last number increasing with the complexity of care that you're providing. There was an interesting question on the discussion board where somebody asked, if I over document, will the insurance company go ahead and give more reimbursement? And unfortunately, the answer to that is no. That's why it's so important that you code correctly to start with. And the one thing I wanted to just make a comment about that was sometimes if I'm not really sure if if I should code it at moderate versus high, the likelihood is I will go ahead and code it at a high acuity. Just because I include so much in my documentation that I don't see why I shouldn't just try to go ahead and get the highest reimbursement that I can. And again, there's another thing I want you to just keep in mind as well when it comes to coding and reimbursement. This justifies the work you're doing for your patient, the care you're providing. So don't ever short yourself, okay? And the other thing I wanted to point out too in terms of coding is also a method that your company will use to track your productivity. So again, that's so important because if you're coding too low, then you're actually gypping yourself of productivity levels. So for instance, if I see a high acuity patient, that increases my productivity. So you have to remember that that also is incorporated into the whole coding situation. So just keep that in mind. Again, I just wanted to review danger signals to know for practice in terms of just different things that you may run across that you need to make sure you're conscious of, that could be an emergency or something that you need to address immediately. For instance, bladder cancer, it's common in elderly patients, mostly in their 70s, and one of their presenting symptoms in bladder cancer is painless hematuria. So you don't want to ever ignore bleeding, okay? And in terms of bladder cancer, the next step would be to order a urinalysis, a urine culture at sensitivity, and a urine for cytology. In acute kidney injury, also known as acute renal failure, again, also common in elderly male patients, 70s, similar symptoms. And again, you don't want to ignore painless hematuria. Acute pyelonephritis, remember we talked about lower UTIs versus upper UTIs, and the pyelonephritis is something we want to avoid. These are patients that can go from sick to very sick very quickly. So you want to make sure you're really screening them to see if they need to be hospitalized, okay? Indications for hospitalization would be they can't keep fluids down, they have a consistent high fever, they look really sick, they already have immunocompromised issues or comorbidities that are causing them to be even more immunocompromised. There's always the suspicion of sepsis, and in that case, you immediately want to have them hospitalized. Or of course, if these are patients that are non-compliant to treatment, whether it's just out of sheer non-compliance or just the inability to be compliant, if they can't afford meds, whatever, these are also patients you want to consider hospitalizing. And then of course we have rhabdomyolysis, and you just want to be very careful with this particular diagnosis because sometimes it's easy to ignore. Usually it's an acute onset of muscle pain with sudden muscle weakness and dark tea-colored urine. Their serum creatinine kinase levels are extremely high. And again, these patients you want to refer immediately to the emergency room. Okay, so again, we're going into module 4 now to talk about prostate, penile, and endocrine metabolic complaints. I did post, again, some more supplementary videos that I thought would be really helpful. So I would definitely encourage you to go ahead and watch them. Again, none of them are that long, but they're nice tidbits to help you remember certain things and solidify certain concepts. So the first thing I wanted to get into were prostate disorders, specifically BPH, prostatitis, and prostate cancer. So the first thing we're going to really get into is BPH, also known as benign prostatic hyperplasia. This is a nodular hyperplasia of the prostate, and it's one of the most common conditions affecting men older than age 40 years old. In terms of testing, you want to do a urinalysis, PSA, prostate health index, urine cultures, urine cytology, and IV pyelogram. The prostate gland, I want you just to review in terms of anatomy. Remember, the prostate gland is a walnut-sized gland positioned at the base of the bladder and in front of the rectum. The prostate gland, which starts enlarging in puberty and then stops growing around 20 years, begins to enlarge again after the age of 50. That's why our BPH starts to affect people over the age of 40. The prostate has 3 distinct zones: the central, peripheral, and the transition zone, which lies adjacent to the urethra. And BPH, or benign prostatic hyperplasia, usually develops primarily in the transition zone, whereas the carcinoma of the prostate usually develops in the peripheral zone. Symptoms of BPH are reported earlier than when clinical evidence becomes apparent, with 25% of men at age 55 years old describing a change in voiding patterns. So that's a big symptom. So usually one of the first things you'll hear in practice is they're complaining that they're peeing differently. In terms of medical management, most patients with BPH can be treated as outpatients. Remember, the goal is to relieve the symptoms of the dysfunctional urination, which is specifically the nocturia that they complain about. Very close to BPH is also something called prostatitis, where it's just an inflammation of the prostate. It is one of several inflammatory or painful conditions affecting the prostate gland, and it accounts for about 25% of all office visits by men, and 50% of men will experience prostatitis at some point in their lifetime. The classification of the type of prostatitis is important for both diagnostic and treatment purposes, so just be very conscious of that. There are different types. Here we have listed acute chronic non-bacterial, which is your most common, and asymptomatic inflammatory. Now, prostatitis is predominantly found in men who are sexually active between the age of 30 to 50. In fact, chronic non-bacterial prostatitis is the most common type. It is 8 times more frequent than bacterial prostatitis. So testing for prostatitis includes a CBC, a urinalysis, a CT or ultrasonography, or a needle biopsy. But in these cases, when we get to the point where we need to do all this testing, the likelihood is we're going to go ahead and make the referral to the urologist. And again, in terms of making consults and referrals, like, I don't know what access you have right now. Where I am in terms of making referrals and consults, it's about a month at minimum in terms of trying to get appointments. So I'm making referrals sooner than later. Okay, in terms of patient education with BPH, we want to make sure that we stress to the patient that taking any kind of medications containing alpha adrenergic agonists or anticholinergic agents can cause acute urinary retention that can result in acute renal failure. So these patients sometimes may require an indwelling urinary catheter until the acute urinary retention is resolved. The most common offending medications that they list, like what they were saying above, over the counter, are various cold and flu preparations. So those are the ones you have to be very careful with. Patients should also be advised to avoid bladder irritants such as coffee, spicy foods, and alcohol. Patients should be instructed to avoid at least every 2 hours to help reduce the possibility of UTI. So in terms of instructing them to avoid at least every 2 hours, that again is kind of like a bladder training technique. They may not have to go every 2 hours, but you're still making them go and get up and sit on the toilet every 2 hours to try to see if they can go. And in terms of bladder irritants, the coffee, spicy foods, and alcohol, those things really make you go more frequently. We don't need to give them more reason to go at this point. Okay, so in terms of prostate disorders, we definitely obviously have to talk about prostate cancer. 95% of all prostate cancers are acinar adenocarcinomas. Most common cancer found in American men, and it ranks as the second in the number of cancer deaths. The problem with prostate cancer is that it's usually asymptomatic early in the disease. And then later on, symptoms include bone pain, weight loss, anemia, shortness of breath, lymphedema, and lymphadenopathy. They use the Gleason score in terms of scoring the level of prostate cancer or the severity of it. The important thing is to make sure that we get timely clinical recognition and treatment of prostate cancer. And it's important to understand the prostate anatomy and function, as we reviewed earlier. Keep in mind that the epithelial cells of the prostate gland are the only source of the PSA. So prostatic cancer is known to have a propensity for the gland's posterior and peripheral zone, thus accounting for the ability to palpate many cases of prostatic cancer through the rectal wall. So that's why it's so easy to feel it when you go in and do the exam. Men with prostate cancer are usually asymptomatic early in the disease and may even be asymptomatic in late stages of the disease. As I said before, we're looking at those latent symptoms, just like in any kind of cancer. It's very similar in terms of latent symptoms with the bone pain, weight loss, anemia. Neurological symptoms sometimes occur with epidural metastasis and cord compression. The patient complaints can also include bladder outlet symptoms or acute urinary retention when you have a very large or locally extensive tumor, although these symptoms are most often due to the BPH. There is no PSA level below which prostate cancer can be definitively ruled out. Rather, the risk of prostate cancer increases as the PSA level increases. As mentioned before, PSA levels may be elevated in individuals with BPH, but with regard to cancer screening, traditionally a PSA level greater than 4 is considered positive, and a level of 4.1 has been considered a threshold for performing a prostatic biopsy. So that's the number, the key number to make sure you're aware of. So once we start hitting 4.1, that's when we have to consider doing a biopsy. Serial PSAs are thought to be more accurate than a single test for prostate cancer screening because persistent elevations increase the risk. So we're looking at a number of PSAs before we make our diagnoses. Age-specific PSA norms have also been suggested as a method to increase the accuracy of the PSA test for the diagnosis of prostate cancer. However, the use of age-specific norms as a biopsy decision point is controversial, given that they may potentially delay detection of prostate cancer in some patients. So really watching the PSA and just making sure you're keeping track. And if the numbers start to drop, great, we'll do a little watchful waiting, but always keeping on top of that patient with follow-up, as well as making that referral when necessary to the urologist. Okay, so penile and testicular disorders. So here we're going to get into erectile dysfunction, epididymitis, testicular torsion, hydrocele, varicocele, testicular cancer, and STIs or sexually transmitted infections. We won't get too much into that, but I did want to bring it up in this particular lecture, obviously, just so that you're clear on, if you see other symptoms in addition to any of the above, you know where to refer them, or where to take your diagnostics or differentials next. Okay, so the first thing we're going to get into is erectile dysfunction. 50% of men older than 40 years old have some degree of ED or erectile dysfunction. Erectile dysfunction is classified as mild if the patient fails to achieve a satisfactory erection in 2 out of 10 attempts. If all attempts at satisfactory erection fail, erectile dysfunction is then classified as severe, while moderate falls somewhere between mild and severe. So they have mild, medium, and moderate in terms of differentiating the severity of the erectile dysfunction. It is difficult to estimate the number of men with ED because the definition is broad, and some men may be reluctant to seek medical attention for the problem. So that's something very, very, this is a very sensitive subject for men, especially when they're talking to it with a female clinician. So just be very sensitive to that. But I would also encourage you to bring it up because it affects people's lives so significantly, relationships, marriages. So it is something I would definitely just mention to your patient, ask them if they're having any issues with that, because there are treatment courses that we could get them that would really improve the quality of their life. So keep in mind, like I said, a lot of men are reluctant to seek medical help for this particular problem, but it's so important to talk to them. Remember, transient and limited episodes of impotence can occur in about half of all adult men at some point in their lives, and it's not pathological. Aging affects sexual functioning, and more than 25% of men older than 65 have erectile dysfunction. Most cases of erectile dysfunction have an identifiable physical as opposed to psychogenic cause. Although the focus is on in this particular course, of course, the focus of figuring out ED or physiological causes, it's also critical to assess both the physical and mental health aspects in a patient with ED, and again, make appropriate specialist referrals if needed. In some cases, ED may result from a combination of both physical and psychological or emotional causes, because such etiologies are not mutually exclusive. And in turn, it is critical to determine whether the patient with ED still experiences sexual arousal despite the inability to achieve or maintain the erection. So that's a very interesting point that you do want to kind of assess in your patient. Like, are they still having the experience of getting sexually aroused? They're just not able to maintain the erection or get an erection, versus not only are they not achieving or maintaining erection, they don't have any sexual desire. Okay, so that can also help pinpoint where you need to lead your plan of care. In terms of epididymitis, this is inflammation of the epididymis. It's an inflammation of the testicle, which results in a unilateral painful testicle known as an epididomyositis. And this is an inflammation where the coiled structure connecting the sperm-producing testes to the vas deferens that allows for maturation and immunosurveillance of the sperm. The inflammation results in scrotal pain, swelling, and induration of the posterior lying epididymis, with eventual scrotal wall edema and involvement of the adjacent testicle, possibly with reactive hydrocele formation. So epididymitis, if you leave it untreated, can then go ahead and lead into a hydrocele, which we'll talk about in a few minutes. So just keep that in mind. There's in terms of the cause of epididymitis, there's a predisposition when the patient has a history of unprotected intercourse or a new sexual partner, a history of UTI with dysuria, or urethral discharge. So this actually is a pretty common thing for men to get when they have a new sexual partner and there's a new bacteria being introduced. So sometimes this does happen. Symptoms also can occur with heavy lifting or straining. Younger sexually active men or older men with a UTI are the patients who most commonly present with this epididymitis. It also but rarely, can occur in pubescent boys, which likely heralds a structural abnormality in the GI tract, in genitourinary tract, I'm sorry. The causes of epididymitis in males younger than 35 are usually sexually transmitted diseases such as chlamydia or gonorrhea infections, but there's usually a difference in the type of discharge. So just keep that in mind when you're looking at the discharge. That's going to help differentiate whether it is epididymitis or an STI, whether it's chlamydia or gonorrhea. Chlamydia infection usually produces a serous urethral discharge, where gonorrhea produces a purulent discharge. So gonorrhea, you're getting more of like a kind of infected-y type looking discharge, versus chlamydia is more kind of clearish yellowish. Okay, so other things we need to definitely talk about are testicular torsion, hydrocele, variocele, and testicular cancer. So testicular torsion is a twisting or rotation of the testes resulting in an acute ischemia. It is a urological emergency, so please, if this is something you even think it might be a problem, you need to send them to the emergency room. The torsion may vary from 90 to 360 degrees around the spermatic cord, and an even more common phenomenon is the torsion of the testicular appendix or appendiceal torsion, in which a small remnant of the Müllerian duct located along the superior portion of the testes twist about its base. So it can occur at any age, from a newborn to the age of 80 years old. However, 2/3 of cases occur between the ages of 10 and 20 years, with a peak incident at 14. So you're looking at your younger men, boys and young men. Testicular torsion is possible in older men, but it is rare. So the most common symptom of testicular torsion is an acute onset of pain accompanied by swelling. If the torsion of the appendix testes is also present with pain, it may be a little more gradual in onset, and they may have pain for several days before seeking attention. The other most common clinical sign of testicular torsion is the absence of the cresmeteric reflex. All right, so please make sure you review what that is. In terms of patient education, with testicular torsion, as many as 2/3 of testes have been salvage may atrophy in the first 2 to 3 years post-torsion. So be very conscious of that. The possibility of testicular atrophy in a salvaged testes, along with depressed sperm counts, necessitates patient education and understanding of these potential sequelae. Patients should be taught to seek immediate care when experiencing testicular pain to prevent permanent sequelae. Okay, so next we're going to get into hydrocele. So remember, just to reiterate, in terms of testicular torsion, it's literally like the testicles are twisted and they're not getting enough oxygen, and it can cause major issues. So that, again, that's an emergency. It's painful, it's acute, and it's acute ischemia to the testicles. So we have to save the testes and get this patient to the emergency room. In terms of a hydrocele is a collection of peritoneal fluid within the scrotum and around the testes between the parietal and visceral layers of the tunica vaginalis, which is a 2-layered sac that surrounds the testes and the spermatic cord. A hydrocele forms when a secretion of fluid into this space outweighs its reabsorption. And these collections may range from only a few millimeters of fluid to an enormous volumes of fluid measured in liters. And once we get into those levels of hydrocele where the patient is holding on to that many liters of fluid, that's when they're going to be in agony, a lot of pain. An varicocele is an abnormal degree of venous dilation of the paniform plexus in the spermatic cord above the testes, which usually results in pain and engorgement of the testes. The patient may present with pain and engorgement, and it's usually a secondary problem with fertility. Most patients with a varicocele often describe the sensation of palpating the affected portion of the scrotum as feeling like a bag of worms. So anytime you think of varicocele, like, you need to think a bag of worms, because that's literally what it feels like inside of the scrotum. After it's been diagnosed, the patient is referred to a surgeon. although most patients do not require surgery because most varicelles are minor. And hopefully we catch it in time that we can deal with it before it gets to that point. In terms of patient education, you want to educate the patient that they should, education for the patient should include an explanation of the disease process, signs, symptoms, and implications. The patient should be taught how to monitor growth and symptoms of the varicelle, especially if it is right-sided. So to relieve pain, the patient should be encouraged to wear scrotal support. For some patients, wearing more supportive jockey shorts or briefs rather than loose boxer shorts is sufficient to relieve discomfort. So again, remember what we're talking about here. Testicular torsion, we're getting a twisting or rotation of the testes resulting in acute ischemia. Again, this is an emergency. A hydrocele, we're getting a collection of fluid in the scrotum. So we're getting a lot of fluid buildup, and it's between the visceral layers of the tunica vaginalis, okay? This can go from big to bigger. It just depends on how much fluid is collecting. A varicelle is an abnormal degree of venous dilation, which usually results in pain and engorgement of the testes. Next, we're getting into testicular cancer. So tumors of the germ cells and seminiferous tubules are the most common testicular carcinomas. Primary testicular neoplasms may arise from any testicular or adnexal cell component. Each testes is covered externally by 2 layers of fascia, okay? The outer layer called the tunica vaginalis and the deeper albuginea layer, which extends internally and divides the testes into 250 to 300 lobules, and each lobule contains seminiferous tubules and the interstitial cells that produce androgens, including testosterone, okay? The epididymis lies along the external surface of each testis and is the site of sperm maturation and storage. Tumors of these germ cells and the seminiferous tubules are the most common testicular carcinomas. All right, again, I will repeat that. Tumors of the germ cells and the seminiferous tubules are the most common testicular carcinomas. Okay, and in terms of patient education on testicular cancer, we want to make sure that the patients are reassured of the high rate of cure associated with testicular cancer. They should also be fully informed of the risk of chemotherapy, radiation therapy, and surgical interventions. For example, adverse effects of chemo include hair loss, immunosuppression, loss of appetite, nausea, and vomiting, while radiation therapy can cause extreme fatigue and interfere with sperm production. So patients that are in their younger years, you want to make sure they're aware that the radiation can affect sperm production, which means can affect their fertility. If they're trying to have babies, this could be a long-term issue. It could also cause diarrhea, vomiting, and skin reactions at the treatment site, as well as nephritis and enteritis in terms of radiation. Complications from retroperitoneal lymph node dissection includes loss of seminal emission and or hypoalbuminemia. So, summarizing all that, guys, keep in mind with this type of treatment, sometimes they can lose their ability to have an orgasm or emit, ejaculate. So these are things you want to just make sure that they're fully aware of and in agreement to, and they have the right support for afterwards. Okay, so in terms of how do we test for any kind of solid masses or fluid in the scrotum, and that we would do by doing a transillumination of the testicle. And all this is, it's a very simple non-invasive test that you can do right in practice to differentiate what you're dealing with. You just take a pen light and you shine it from behind a scrotal lump to observe whether the light travels through the scrotum and it illuminates the lesion. If this technique helps to assess whether the mass is fluid filled or not, because if it's filled with fluid, the light will transilluminate, versus if it's a mass, a soft mass or a solid mass, the light will not transilluminate. So that will help you differentiate whether we're dealing with fluid or a mass. So again, you just take that pen light, press it up against the scrotum. If the light goes through, we know we're dealing with fluid. So a testicular tumor, for instance, will not transilluminate as solid tumors block the light, okay? Also a varicelle, or also known as a bag of worms, as we talked about before, will also not transilluminate. Okay, let's review. A 39-year-old male complains of swelling on the right scrotum that is mildly tender for a few weeks. There is a pressure-like sensation. The right scrotum is larger than the left scrotum. Which of the following tests is appropriate for this patient? Okay, hopefully you just looked at the previous slide. The correct answer is transillumination. The patient likely has a hydrocele on the right scrotum, and the transillumination will show that the light glow is much larger and brighter on the affected side compared with the unaffected side. Once you make this diagnosis, the next step would be to get a urologist involved in his care. Okay, sexually transmitted infections, so STIs, okay? So we just wanted to briefly talk about this. I wanted to make sure we got into this a little bit, specifically since we're talking about different types of penile and testicular disorders. We mentioned before chlamydia and gonorrhea in terms of making sure you're not diagnosing, mixing that up with your epididymitis symptoms. So keep in mind, STIs in men and women are caused by viruses, bacteria, and parasites that can occur in the throat, eyes, perianal areas, anal areas, external genitalia, vestibular glands, vagina, cervix, uterus, or adnexa. Sexually transmitted infections spread through, obviously, sexual intercourse or intimate person-to-person contact. An STI typically occurs when the mucous membranes of these areas are exposed to specific pathogens. The most common STIs include herpes simplex virus or HSV, HIV, HPV or the human papillomavirus, chlamydia, gonorrhea, trichomonas, and treponema pallidum, which is the causative agent of syphilis. Less common STIs include cancroids, Klebsiella, mycoplasma, and Hep B, Hep C, and scabies. Staphylococcus aureus also is known to be transmitted through sexual contact. Some common vaginal infections like candida or yeast infections, also bacterial vaginosis, also may be related to sexual activity by causing a change in the vaginal pH. However, they are not actually considered STIs. I would definitely encourage you guys to look at table 51.1 in your textbook because it does present the most causative pathogens for common STIs. So the 4 common STIs that are treated with antibiotics include chlamydia, gonorrhea, syphilis, and trichomonas. Viral STIs like HSV, HPV, and HIV, although chronic, can be treated and managed, okay? Untreated or inadequately treated STIs can cause serious health issues in men and women. In women, mucopurulent cervicitis can result from infection with multiple organisms, including chlamydia, gonorrhea, syphilis, and genital herpes. Untreated, this condition can lead to ascending infection and affect the uterus, fallopian tubes, and ovaries. So we know this, we know that if we leave STDs or STIs untreated, it can obviously lead to further infection and problems, as well as give women fertility issues and possibly lead them to higher risk for cancer. In terms of men, chronic inflammation of the prostate can also occur, leading to an increased risk of prostate cancer. So if you're leaving STDs or STIs untreated, that can lead to chronic inflammation of the prostate, which can obviously lead to an increased risk of prostate cancer. In both men and women, untreated syphilis can actually lead to a tertiary form of infection that could cause serious injury to the central nervous system. One of the most common STIs that I wanted to make sure I mentioned is HPV. I'm sure you've all heard of that. There are more than 100 serotypes of HPV, and 40 of them can infect the genitalia. Of these 40 types, 13, remember that number, 13 serotypes of HPV are considered high risk for further disease complication. High-risk HPV serotypes can be oncogenic, and persistent infection can progress to cancers of the genital tract, such as cervical, vaginal, and penile. Infection with low-risk HPV serotypes causes genital warts on male and female genitalia. Although they're unsightly, they generally do not pose much of a health risk unless there's a bulky growth in immunocompromised hosts. which is complicated by bleeding sometimes. So again, the main thing with the STDs or STIs is to make sure they're not left untreated, because again, it can lead to further issues. So of course, the most viral STI is HIV. Left untreated, HIV will progress to AIDS over a period of 2 to 10 years, destroying the immune system and leading to an increasing number of opportunistic fatal infection of the lungs, skin, and genitourinary tract. Educating patients about reducing their risk behaviors is paramount in decreasing overall morbidity and mortality associated with STIs. Effective education that you should make sure you emphasize with your patients include prevention and result in behavioral changes that hopefully help reduce the risk of contracting and spreading the STIs. You also want to do primary prevention behaviors, which include HPV and HPV vaccinations. Of course, encouraging your patients to use condoms 100% all of the time, delaying sexual debut, and limiting the number of sexual partners. Secondary prevention measures include cervical cancer screening beginning at age 21 and STI screening in patients with high-risk behaviors. That includes women younger than 25 and during pregnancy. Of course, if any of them had to be treated, you want to make sure you're teaching your patients the importance of medication compliance, reinforcing the need for their partner as well to be treated if necessary, and discussing the risk of reinfection. And these are all examples of tertiary prevention. Remember, we talked about primary, secondary, and tertiary prevention. Well, these are where you're seeing how that is actually an effect in your clinical practice. And again, patients should be assessed for such risk at each visit, especially if they have a history of being sexually promiscuous. Due to the chronicity of viral STIs like HPV, HSV, HBV, HCV, and HIV, these affected patients need education, counseling, and compassionate care. You need to make sure you discuss with them the expected course of their illness, that remission and progression potential, the importance of managing their outbreaks and preventing transmission are all topics that you should be presenting and reinforcing with your patient at pretty much every visit. Keep in mind, these patients also may benefit from some outside sources of individual or group counseling, support groups, more frequent office visits, or any kind of age-appropriate literature that would help solidify the importance of making sure they manage these infections if they do have them. Okay, so let's just do a quick review of each one of those things we just discussed: BPH, epididymitis, hydrocele, prostatitis, and erectile dysfunction. So here again, BPH, I just wanted to make sure we understand what it is. Look at this diagram to give you a good visual understanding of what's happening in BPH. Keep in mind the prostate is enlarged, it's compressing the urethra, and then we're getting urinary retention, which is affecting the urinary flow. Okay, so initial evaluation in terms of diagnosing and your algorithms of how you proceed. These are what you're looking at. You're looking at your obligatory evaluations versus optional evaluations. So obligatory meaning these are the basic standards that you will be held accountable for in terms of coming up with your diagnosis and legitimately having all of the appropriate documentation in place. These things include your medical history. You want to make sure you're assessing for symptoms, doing your physical exam with a DRE and a urinalysis. Okay, pharmacotherapy, that's when you're going to get into discussing treatment options with your patient. And the other optional evaluations can include your PSA, of course, flow rate recording residual urine, an ultrasound, or an endoscopy of your lower urinary tract. Keep in mind, there are two documented mechanisms of obstruction when it comes to BPH. There's static and dynamic. Static constriction is caused by the buildup of the prostatic tissue with direct obstruction of the bladder neck. Versus dynamic. Dynamic constriction is an increase in the prostatic muscle tone through the adrenergic stimulation, leading to constriction of the bladder neck. Obstruction of the bladder outlet forces the bladder to generate higher pressures than normal to achieve micturition. So increased muscle mass in the bladder leads to reduced bladder elasticity and compliance, which manifests as reduction in bladder capacity. So if the bladder neck obstruction is not relieved, the bladder smooth muscle begins to be replaced by connective tissue, leading to bladder failure. So we use a standardized questionnaire, such as the American Urological Association Symptom Index, which is in your book on table 49.1, and it's known as the International Prostatic Symptom Score, and it's important for assessing the impact of BPH on the patient. To be honest with you, I've never done this questionnaire, but I do feel like it would actually be very beneficial, because this questionnaire was designed to uncover the degree of symptomology that each patient, in each patient, and it should be calculated before starting therapy, because this will give you a good reference point later on once you have started therapy to see if it's actually effective. There are 7 items on this questionnaire that determine the severity of obstruction or irritative symptoms. And they actually, the scores are helpful to quantify the patient's symptoms. So a score of 7 or higher on this, on the AUASI tool questionnaire, can actually reinforce the need for further investigation of the cause of the symptoms. Although the scores alone are not diagnostic, they do help support the diagnosis, as well as being useful in following a patient after initiating therapy to track the disease symptoms. Of course, in addition to this questionnaire, you're going to be doing a detailed urinary history to rule out other possible causes of symptoms. A digital rectal exam is done to determine enlargement of the prostate gland. So the prostate in BPH is usually diffusely smooth and enlarged. If the prostate is nodular and unusually firm, then we're concerned about prostate cancer. Again, in benign prostatic hyperplasia, when you do a prostate exam, usually you're going to feel the prostate is smooth and enlarged. If you're feeling that it's nodular and kind of lumpy and firm, then we're very concerned about prostate cancer. So that's when you need to make your referral. The size of the prostate does not correlate with the severity of the symptoms in men with BPH. And keep in mind, many men with palpably enlarged prostates are asymptomatic, where sometimes some patients with small prostates actually have irritative or obstructive symptoms. So a focused neurologic exam should be performed on these patients to help determine if the dysfunctional urinary symptoms could possibly be related to a neurological disorder as opposed to just the prostate. So keep that in mind. Epididymitis. So here we have an irritation and swelling of the epididymis, and that's right there in the picture. In table 1 here, I've listed some etiologies of what the epididymis could be caused from. Remember your risk factors and your common bacterial pathogens. So when they have this inflammation, these patients are complaining of scrotal pain, swelling, and induration of the posterior lying epididymis, with eventual scrotal wall edema and involvement in the adjacent testicle, possibly with reactive hydrocell formation. So not only do you have an epididymis with swelling and irritation of the epididymis, but then you can also, it can lead to a hydrocell forming because of all the swelling. So there is a predisposition to epididymitis when the patient has a history of unprotected intercourse, a new sexual partner, a history of UTI with dysuria, or urethral discharge. Symptoms may also occur with heavy lifting or straining. And again, younger sexually active men or older men with UTI are the patients who most commonly present with this. A lot of the times, the bacteria very commonly, it's the cause of epididymis, is actually E. coli or Staphylococcus aureus. So the major complaint of patients with epididymitis is scrotal pain that often radiates along the spermiatic cord or to the flank. The pain may appear relatively acute over several hours, and many men experience pain at the tip of the penis and complain of urethral discharge or other symptoms of a UTI, such as frequency of urination, dysuria, cloudy urine, or hematuria. So you want to make sure you evaluate the testes and the epididymis, and you also want to make sure that they don't have any other systemic infection symptoms going on, like fever or chills. These patients should really be instructed to limit their activity and immobilize the scrotal contents, meaning, wear a jock strap or something just to give them support, because that can help relieve the pain and aid in treating the infection. The patient will need to wear an athletic supporter and avoid sexual contact and physical activity, as long as the pain persists. Patient education includes stressing the need to complete the full course of all the antibiotics, even after the patient becomes asymptomatic. So just make sure they finish their medication. And of course, if their symptoms come back or they don't actually ever really go away, they need to follow up with you as well. Okay, so back to the hydrocele. So again, that's a collection of fluid in the sac next to the testes, and it can vary in size depending on, how much fluid is accumulated. So remember, the hydrocele forms when secretion of fluid into this potential space outweighs its reabsorption. The collection can range from a few milliliters to an enormous volume measured in liters. Patients with hydroceles typically present with swelling in the scrotum or inguinal canal. If the size of the scrotum fluctuates, a communicating hydrocele could exist. Hydroceles are usually painless, although patients report a sense of heaviness in the scrotum. That's because of the fluid buildup. And if pain is present, it may radiate to the lower back. What we're doing is our transillumination with a pen light in a darkened room during the physical exam. The trapped fluid appears like a light pink, yellow, or red, and the hydrocele can be illuminated to show the full size and shape, which assist in the diagnoses. Remember, the testes themselves do not transilluminate, nor do the hematomas. It's the fluid inside. So follow-up and referrals, make sure you're monitoring this patient at 3-month intervals until the decision is made for or against surgery. Post-operatively, the patient monitoring should be at 2 to 3 week intervals, followed by 2 to 3 month intervals until there is resolution. Post-operative traumatic hydroceles are common and usually resolve spontaneously. All other possible complications may be injury to the spermiotic vessels or a hematoma secondary to surgery or a wound infection. Again, with these patients, you want to make sure you're educating regarding an explanation of the disease process, what the management plan is in terms of, are they going to have surgery, and along with reassurance of overall benign nature of the condition, depending on the underlying cause. Okay, prostatitis. Again, reviewing, so this is an inflammation of the prostate. It can be caused by a traumatic injury to the prostate or bacteria that got into the prostate from urine or during sex. Prostatitis is one of several inflammatory and or painful conditions affecting the prostate gland, and it accounts for about 25% of all visits by men. And like I said before, 50% of men will experience this in their lifetime. The classification of the type of prostatitis is important for both diagnostic and treatment purposes. So remember, we have acute bacterial prostatitis, chronic bacterial prostatitis, non-bacterial prostatitis, or prostatodynia. Chronic non-bacterial prostatitis is the most common type. It is 8 times more frequent than bacterial prostatitis, and it can be acute or chronic. Obviously, acute prostatitis tends to start quickly, while chronic tends to last or go over a long period of time. An inflamed prostate without any symptoms is called an asymptomatic prostatitis, and this condition is usually discovered when you're diagnosing something else. So keep in mind, BPH causes a person to have an enlarged prostate. This condition becomes more common as men age. As the prostate enlarges, it squeezes and blocks the urethra, making it hard to empty the bladder completely. On the other hand, prostatitis is more likely to affect men ages 50 or younger, versus BPH usually occurs in men over age 50. So just to review the different types of prostatitis, again, we have our acute, chronic, and non-bacterial. So the practitioner should assess the patient for signs and symptoms listed in the focus on history in your textbook. The rectal examination should be performed gently with care because vigorous manipulation of the prostate can result in septicemia. And in chronic prostatitis, the rectal exam may reveal a tender prostate, but it is not usually swollen or boggy. So in terms of tests, diagnostic tests, a complete CBC will show leukocytosis and a shift to the left if the patient has acute bacterial prostatitis. In acute prostatitis, a urinalysis will show bacteriuria, pyuria, and possibly hematuria. In chronic prostatitis, it is necessary to culture the expressed prostatic secretions in order to confirm diagnoses. So prostatitic massage is controversial, and some clinicians feel that vigorous prostatic massage can lead to bacteremia. If you're getting to a point where you're considering that prostatic massage, I would highly suggest you refer your patient to a urologist. Prostatic massage definitely takes practice, and it can be a little uncomfortable performing it. So again, if that's something that you're getting to the point with your patient, I would consider definitely refer them to urologists. A urine sample from a patient with non-bacterial prostatitis will show the presence of white blood cells, but the urine culture will be negative. There are no abnormal laboratory findings associated with prostatodynia. If malignancy or abscess is suspected, you want to do a computed tomography scanning or transrectal ultrasonography is indicated. A needle biopsy of the mass or aspiration of the abscess for culture may be done by the urologist. Again, a lot of these things, if we're dealing, especially with chronic, we're going to be referring to urology. But it's good for you to know and be aware of what the treatment plan would look like for these particular patients. The main principle of management for prostatitis is to treat the patient on an outpatient basis if he does not have a fever. However, an extremely ill patient with bacterial prostatitis should be treated in the hospital, as hospitalization obviously may be necessary if the patient is toxic, immunocompromised, has a proven or suspected abscess, or has signs of urosepsis. It is extremely important that the patient with acute bacterial prostatitis be kept well hydrated, and percutaneous suprapubic catheterization may be required if the patient develops urinary retention. Urethral catheterization would be contraindicated in patients with acute bacterial prostatitis because we want to avoid trauma to the inflamed prostate and possible seeding of bacteria. So here is what prostate massage would look like. Usually you're secreting, if you do the massage, you want to make sure that you're educating the patient as to what to expect. The rationale behind this is to express prostatic secretions. That way we can get, run labs on it and diagnose the patient with prostatitis or aid in the diagnosis of prostatic cancer. So what happens is after a prostate massage, it increases the PSA levels immediately after the procedure. And then what we want to do is within 2 weeks, we want to draw the PSA. So you want to make sure you instruct the client that after the massage, they may feel the urge to urinate or feel rectal pressure 15 to 60 minutes after the massage. And of course, if they feel any chills, myalgia, rigors, or get a temperature after the procedure, they need to obviously notify you immediately. So in terms of interpreting, like when the massage is going on, if you're getting, if you are able to express the prostate secretions, you're looking at the secretions, normal would be clear, infected, of course, would be milky or yellow, which makes sense, worm-like material, or precipitates would be some kind of calculi. And then, of course, if we didn't get any drainage, we're concerned about obstructed ducts. Then we have, the book likes to give these what they call the iceberg of erectile dysfunction. And it just basically goes through the different points that you need to make sure in terms of holistic management that you're looking at all these different particular aspects of the patient in terms of their continuum of care, and how you can support this patient. So obviously we're giving them the caring process in terms of support and patience and active listening and advocacy, and getting them the right referrals to the right support groups.
It's 7 o'clock.
We're giving them education. You can consider the vacuum device. There's a lot of different devices and thoughts behind erectile dysfunction that we'll go into. There's the vacuum constrictive device. There's penile prosthetics. There's penile revascularization, low intensity shockwave therapy, hormone therapy. There's all kinds of things that these patients can try to get back to their original sexual activity. Of course, you want to meet with the patient and their partner if possible to go over this and provide support. We want to reduce or we want to discuss pharmacological thought processes. Again, the hormone therapy, testosterone, different avenues in terms of that. And you want to make sure that you're just giving them as much education as you can. So the other thing I wanted to make sure is, like, in terms of normal sexual functioning, keep in mind in men, they have 5 phases. They have the libido, erection, ejaculation, orgasm, and demusance. For an erection to occur, they have to have enough automatic and somatic nerve supply to the penis and the arteries. So in order for this to happen, all the muscles and the neurotransmitters need to all be in sync. One thing that you need to make sure you're aware of are that there are many medications that can be common causes of erectile dysfunction, whether directly or by adverse effects. So drugs like methyldopa, clonidine, risperidone, they can definitely cause loss of erection. However, beta adrenergic blocking agents and spironolactone can actually cause loss of libido. So we're talking about 2 different things. Again, libido being your actual sexual desire versus loss of erection is the actual inability to get an erection. So certain drugs like calcium channel blockers and can increase prolactin secretion and therefore also cause erectile dysfunction. The absence of emission may be caused by 3 different types of organic disorders. We could have retrograde ejaculation, sympathetic denervation, and androgen deficiency. Retrograde ejaculation may occur after surgery on the bladder neck, or it may develop spontaneously in a male patient with diabetes. If libido and erectile function are normal, the absence of orgasm is almost always due to a psychiatric disorder. So again, figure out what's happening. That way you know you're making the right referrals and plan of care for this patient. Okay, so treatments for erectile dysfunction. Again, there are a number of options available for treatment. If the organic cause cannot be found, these men will most likely benefit from behaviorally based sex therapy. Pharmacological treatments include hormone therapy, and those drugs that are commonly prescribed are presented in your text on table 50.1. Non-pharmacological interventions, including vacuum constrictive devices, vasoactive therapy, penile prosthesis, and penile revascularization are the ones that I wanted to make sure we talked about here. In terms of vacuum constriction devices, most vacuum devices work in similar ways using a process that takes about 2 minutes. The patient would insert his penis into a cylinder and then uses a pump to create a partial vacuum, which causes venous blood to enter the corpora cavernosa, which leads to rigidity of the penis. Once a sufficient erection is achieved, a latex constriction ring is placed around the base of the penis to help maintain the erection, and then he's then able to have sex. This is a non-invasive procedure. Complications are rare. The devices are now available over the counter, and they cost between $300 to $500. Another option is vasoactive therapy. And this is basically the development of drugs that decreases the breakdown of 5-cyclic guanosine monophosphate, which has revolutionized ED treatment. It's called CGMP, and it's the intracellular second messenger of nitric oxide, which is primarily a vasodilator and neurotransmitter involved in the erectile response. So of course, the first of the drugs that we all know about is Viagra, or it's also called sildenafil is the generic name, and it results in an increased blood flow necessary for successful penile erection. The standard dose of Viagra is 50 milligrams at least 1 hour before sexual activity. And the contraindication that you need to be very clear about with these patients is hypotension. Okay. The contraindications that are listed for this particular drug, again, are found on your table 50.1 in your text. I would definitely encourage you to review that. Other meds like Viagra in the same class of medications include Levitra, Stendra, and Cialis. Okay. So another treatment for ED is called vasoactive prostaglandins. And these are injections that are literally injected directly into the penis. And from these injections, erection can occur within 20 minutes and last approximately 30 to 60 minutes. Prolonged erection, also known as priapism, make sure you're aware of that word. Priapism is a prolonged erection, can occur, but it's very rare. But if it does, the patient should obviously be instructed to go to the emergency room immediately. So penile prosthetics include, there's several different prosthetic devices. They can be surgically implanted into the penis and are available in a variety of sizes and diameters. They are placed directly in the corporal bodies, and they may be rigid, semi-firm, hinged, or inflatable. The inflatable devices are more naturally appearing. However, there's more opportunity for mechanical failure. Implantation of these prosthetics, which is highly reliable but invasive, may help men who have failed therapy with other methods. It is very expensive and not without risks. Some implantation devices may be covered by some insurance plans, but most patients desiring implants prefer spontaneity and therefore choose this invasive treatment. Significant problems associated with implants are infection, erosion, and occasional mechanical failure. The most common types of implants are non-hydraulic, using semi-rigid rods, and hydraulics, using inflatables. Both types of implants involve surgical placement of 2 cylinders inside the corpus cavernosum. Healing with these kind of devices takes about 4 to 6 weeks, and after which the patient may have intercourse. The next thing is penile revascularization. It's limited in terms of some patients fail to have a sufficient erection even after the procedure. Patients with arterial disorders may be candidates for the various procedures, which include an endarterectomy and balloon dilation or arterial bypass. In younger men, several conditions may warrant penile revascularization surgery. Men younger than 45 whose impotence is caused by severe pelvic trauma are the best candidates for this type of surgery. In patients with impotence of sudden onset, the possibility that trauma to the peritoneum or pelvis may have led to vascular injury should be considered, or a congenital shunt may be ruled out if any patient who reports that he has never had a full erection. And last but not least, we have low intensity shockwave therapy, which has met with success in Europe in patients with severe erectile dysfunction who were unresponsive to treatment with Viagra or Cialis or Levitra. This shockwave therapy is not yet approved in the US, but research is ongoing, and it believes that low intensity shockwave therapy, or LIST, L-A-S-T, promotes the release of angiogenic factors that lead to revascularization of the penis. So again, that's not approved yet in the US, but Europe is working on it, and they're still doing studies about it. Okay, so patient education in terms of erectile dysfunction. The primary role of the provider in educating the patient with ED is to stress the importance of management of their chronic conditions, such as hypertension, diabetes, and stress. Making sure they're managing these conditions will help deter the erectile dysfunction, so to speak. Guided imagery, regular exercise, and yoga may be recommended as modalities to reduce stress. Tight control of blood pressure and blood sugar should be encouraged as a way to limit further deterioration of erectile dysfunction. In addition, counseling for cyclogenic causes of ED is essential. So if any of these patients are their cause of ED is mental, psychiatric issues are going on, whether it's stress, anxiety, any kind of PTSD from, any sexual abuse encounters, all of these need to be addressed with a counselor. So make sure you refer those patients for that. Instructions regarding topical hormone formulation should include warnings regarding the possibility of transfer to sexual partners during intimate contact, as well as the general risk to women and children from unintended exposure to medications affecting the hormonal axis. The risks of hormonal overexposure, example, cardiac events, should also be reviewed, including BPH, an increased risk of obstructive sleep apnea, polycythemia, peripheral edema, and both cardiac and hepatic dysfunction. So remember, you don't want these topical hormones that these male patients are putting on touching anybody, like the women or children in their homes, because it can have some, adverse reactions. Okay, now let's get into the common endocrine and metabolic complaints. We have hypocalcemia, gynecomastia, hirsutism, increased neck size, and of course the 3 Ps, polydipsia, polyphagia, and polyuria. So keep in mind, hypocalcemia is defined as a calcium of less than 8.5 milligrams per deciliter. In response to hypocalcemia, the secretion of the parathyroid hormone increases, which leads to mobilization of calcium stores from the bone and an increase in the absorption of calcium in the intestines. Neuromuscular signs and symptoms may occur in the presence of hypo or low calcium because calcium is an important mediator in neuromuscular transmission and other intracellular biochemical activities. So acute neuromuscular irritability occurs when your calcium drops abruptly by 2 to 3 milligrams. And your neuromuscular signs and symptoms include Trousseau sign, which is the violent, painful contraction of the hands and the feet, as well as Chopsteck sign, which is the second neuromuscular sign associated with hypocalcemia. And that is an abnormal unilateral spasm of the facial muscle when the facial nerve is tapped. So make sure you're very well aware of your hypocalcemia signs, your Trousseau and your Chopsteck sign. Other hypocalcemia symptoms include various neuropsychiatric disorders, irritability and emotional instability, problems with memory, and psychosis. They can also complain of paresthesias, fatigue, muscle cramps, or muscle weakness. Chronic hypocalcemia also can cause the skin to be coarse, dry, and scaly. Alopecia may be present with thinning of the eyebrows and lashes, usually with low calcium. The nails are often rigid, brittle, and thin with transverse grooves. So make sure you're looking at those nails when you're assessing your patients. That could be a clear indication that their calcium is low. Then we have gynecomastia, which is an enlargement of the glandular breast tissue in men, which may be present in before or after puberty. It may be present unilaterally or progress to bilateral symmetrical enlargement. Gynecomastia results from an imbalance of androgen and estrogen or an increase in prolactin. Growth hormones, estrogen, and corticosteroids stimulate ductal growth in the breasts. It's estimated to affect about 12 to 40% of men in the United States, and it is present in approximately 60% of men older than 50 due to a decrease in your testosterone levels. So transient gynecomastia occurs in male neonates, 60 to 90%, and at puberty about 50 to 60%. Next, we have hirsutism. Hirsutism is an increase in terminal hair growth on the face, chest, back, lower abdomen, pubic area, and inner thighs. It is approximately in about 5% of women, and almost 25% of these women have terminal hair growth on the face, especially on the upper lip. It is caused by an increased secretion of androgens by the ovary or adrenal glands, or an increased sensitivity to androgens. And it is often accompanied by menstrual irregularities. There are 2 types of hirsutism, vellus and terminal. Vellus hair is found almost over most of the body, and is fine, soft, and unpigmented. During puberty, vellus hair often changes to terminal hair in the presence of increased androgens. Terminal hairs are, turn darker, and they're coarse, and they're pigmented, and they're thicker compared to the vellus hair. So it basically is like baby hair to grown-up hair. That's what I kind of think of when I think of vellus and terminal. Terminal hairs are found on the scalp, eyebrows, and the axillary and pubic areas after puberty, and they are found in lesser abundance on the extremities. So remember, hirsutism is an overgrowth of hair, terminal hair growth, and we have 2 types, vellus and terminal. Next, we'll get to our increased neck size. So along with the extensive muscular and vascular neurologic network, the neck contains approximately 75 lymph nodes. The trachea, the larynx, the pharynx, and the submandibular and salivary glands, cervical vertebrae, and the parathyroid and thyroid glands. Pathology in one of these structures or in an area that is drained by one of the many cervical lymph node chains may increase the neck size. So when you hear about all those things in the neck, you realize why the potential for it to be bigger is there. A patient with an increased neck size may present with complaints that shirt collars have become too tight. The patient should be evaluated immediately for any difficulties swallowing or problems with breathing. A rapid diagnostic workup with a specialty referral is indicated in the presence of either symptom. So again, symptoms that you're really are going to be red flags in your patients are complaints that the shirt collars have become too tight. So if our neck is enlarging, something is wrong. Remember, that leads right to our airway, and we want to make sure that there's nothing that's causing any problems with difficulty swallowing or difficulty breathing. Then we get to our 3 Ps: polydipsia, polyphagia, polyuria. Polydipsia is excessive thirst, both associated with endocrine diseases and certain medications. Polydipsia may accompany increased urine output, which is polyuria, which can be related to excessive loss of water and salt. Polyphagia refers to excessive eating before satiety. This symptom can present as a persistent or intermittent condition resulting from endocrine and psychological disorders. Certain drugs are also known to cause polyphagia, and elevated T4 levels increase metabolism and thus the body's need for calories, also causing polyphagia. So again, if we have those elevated T4 levels, we may become symptomatic with polyphagia. Polyuria is a condition associated with increased urine production. It is defined as an excretion of more than 3,000 milliliters of urine in a day. Any condition that increases hyperosmolar states will increase urination as a consequence of osmotic diuresis. The patient with polyuria is at risk for developing a fluid volume deficit that could result in hypovolemia. So remember, these are just symptoms. So here is a summary of each one of those. So again, hypocalcemia, less than 8.5 per deciliter. We're looking at our neuromuscular signs and symptoms, Trotstek signs, carpal pedal spasms, or Trousseau sign. That's another name for Trousseau sign. We're looking at gynecomastia, where we have an enlargement of granular breast tissue in men. We have hirsutism, where we're looking at the 3 different types of hirsutism. And then we have increased neck size. And remember, that's could be an emergency situation. So make sure if they're telling you that their neck collars are getting too tight, we need to make sure we are evaluating for any swallowing or breathing difficulty immediately. Again, here is your 3 Ps: excessive thirst, excessive eating before satiety, and excretion of more than 3 liters of urine per day would be your polyuria. So in terms of your differentials with your polydipsia, polyphagia, and polyuria, this is where you want to start considering. Of course, one of the first things we think of with the 3 Ps is our diabetes mellitus and renal disease. So once we've ruled that out, we can go, if we're just looking at polydipsia and polyuria, we can also consider some other differentials, including dehydration, hypokalemia, psychogenic Sheehan syndrome, sickle cell anemia. You see, you have a lot of different options depending on which P is presenting itself. Okay, glandular disorders. So next we're getting into hyperthyroidism, hypothyroidism, thyroid cancer, and Cushing syndrome. In hyperthyroidism, it's caused by an excessive secretion and synthesis of one or both of the thyroid hormones, T4 and T3. Although many clinicians use the terms interchangeably, thyroid toxicosis is a more general term that encompasses hyperthyroidism, as well as exogenous thyroid hormone intake and subacute thyroiditis, in which acute inflammation of the thyroid gland results in the rapid excretion of stored thyroid hormones. The clinical manifestations of hyperthyroidism result from the excessive thyroid hormone on body tissues, resulting in alterations in growth, metabolism, and development. Long-term effects of inadequately treated overt hyperthyroidism include heart disease, osteoporosis, mental illness, and infertility. Versus hypothyroidism, which is slow progression of thyroid hypofunction. It has an insidious onset and progresses slowly. It's a treatable disorder in which there's a slow progression of thyroid hypofunction, which are followed by signs and symptoms, including or indicating thyroid failure. Hypothyroidism is a common treatable disorder in which there is a slow progression of thyroid hypofunction. The thing that we need to make sure that we are being conscious of is that the incidence of hypothyroidism varies with age, gender, and geographic and environmental factors. The incidence from numerous survey ranges from 3 to 14 cases per 1,000 women, with significantly fewer cases reported in men. In fact, the incidence in women is 2 to 8 times greater than it is in men. So that's an interesting thing. And keep in mind, it is estimated that as much as 4.6% of the US population has an elevated TSH, with a higher incidence in European Americans than compared to Hispanics or African Americans. So European Americans tend to have the higher incidence of this. The most common worldwide cause of thyroid disorders is iodine deficiency, with a worldwide prevalence of 2 to 5%. In the US, where iodine ingestion is usually adequate due to the ready availability of iodized salt, autoimmune processes are the most primary cause of thyroid disease. Hashimoto's thyroiditis, a type of primary hypothyroidism, is the most common form of autoimmune thyroid disease. This type of hypothyroidism occurs at least 4 times more often in women than in men, with an average age from 30 to 60 years old. Most of the time I see Hashimoto's in younger women. I've really only seen it pretty much there in Hashimoto thyroiditis, 35, 40 years old. Okay, then we have thyroid cancer, which is the most endocrine-related cancer, and anaplastic tumors are the fastest growing of all types of thyroid neoplasms, and they are also associated with the highest mortality rate. Then we have Cushing's syndrome, which is a persistent, inappropriate hypercortisolemia. We'll get more into that. So just to go back to hyperthyroidism, here's your common anti-thyroid medications. We have PTU and Tapazole. So just keep in mind, those are our typical treatments. So after diagnosis, the patient with hyperthyroidism should be given information about various treatment options, including the risk and benefits of each treatment and the consequences of no treatment. Patients need to know that if they take 4 to 6 weeks, that it may take 4 to 6 weeks after starting medication to notice an improvement in their symptoms because of the amount of stored hormone in the thyroid gland. Patients who are unaware of this phenomenon may not comply with the treatment regimen, so they need to have written instructions to monitor for signs and symptoms of a thyroid storm, as well as hypothyroidism once treatment is initiated. Make sure you inform your patients of the potential adverse reactions of all medications, particularly anti-thyroid preparations, and to discontinue the medication and notify their primary care practitioner if they experience a fever, sore throat, or malaise develops. If they do end up receiving radioactive iodine therapy, they should make sure to avoid contact with infants, children, and pregnant women for 7 days after ingestion. And any women who are receiving this treatment should also not be told to not breastfeed for at least 3 to 6 months, because radioactive iodine is excreted in breast milk and can ablate the infant's thyroid. So that's very important. You let your patients know that. You need to make sure after they get ablative therapy, if they do go that route, that they get adequate rest and exercise afterwards. They need to make sure to promote lots of relaxation time with like feedback, music, meditation, guided imagery. So important in managing after this type of therapy. Just also as a side note, some patients may experience depression as the level of thyroid hormones change, and this should be discussed with patients who should be instructed to report any symptoms of worsening depression or anxiety to make sure they get prompt evaluation, because you don't want them to have any extreme situations where they don't feel like they have support. Patients who also have any issues with exophthalmos should wear dark protective lenses when outdoors during the day. They may need to use artificial tears to relieve the dryness and protect their corneas. Glasses or other eye protection should be worn during any activity that may introduce dust or dirt into their eyes. And a sleeping mask should be worn at night if the patient cannot close their eyes adequately. Sometimes that happens. Okay, so causes of hypothyroidism. So remember, localized thyroid disease is the most common cause of hypothyroidism in the US, namely Hashimoto's autoimmune thyroiditis. Worldwide, like I said before, iodine deficiency is the most common cause, but we have different causes here. Please make sure you review these. This is table 57.4 in your book. We have loss of functional thyroid tissue, central hyperthyroidism, and transient hypothyroidism. So keep in mind, patients with hypothyroidism may have facial puffiness, periorbital edema, dry, thick skin, dry, coarse, brittle hair, brittle nails, slow speech, bradykinesia. These patients are very, very easy to distinguish. If they do have these full-blown symptoms, you'll know right away. You'll be like, oh, that's a thyroid issue. They have hoarseness and enlarged tongue, bradycardia. A lot of them have psychological disorders and pitting edema of the lower extremities. Remember, you can also look at table 57.5. That also will summarize your clinical presentation of hypothyroidism. And that's this table right here. I made sure to put that in here just to make sure you guys review this. In 2015, keep in mind the USPSTF, or the United States Preventative Task Force, reviewed the 2004 recommendations for thyroid screening and reaffirmed that there is sufficient evidence for or against routine screening for thyroid disease in adults without symptoms. Although, in turn, they still do not recommend routine screening in adults without specific risk factors. However, all patients with an abnormal thyroid exam or prior history of any medical or surgically treated thyroid disease should be screened with a yearly serum TSH measurement while stable. In addition, patients with other autoimmune diseases such as diabetes or pernicious anemia, unexplained depression, or other psychiatric disorders, there's actually quite a few different lists, should also be screened with TSH measurements. So make sure you're reviewing your USPSTF guidelines. We talked about that in our first class, because they will give you the standards in terms of how often, how frequently you should be testing for whatever it is you're concerned about, depending on what your patient's status is and their comorbidities. Remember, the diagnosis of hypothyroidism is made by measuring serum TSH. TSH and FT4 should also be used to monitor treatment. Okay, so patient education with hypothyroidism. During follow-up visits, should be placed on compliance with lifelong thyroid therapy if it's indicated for this particular patient. You want to review the symptoms of hypo and hyperthyroidism and stress the importance of adherence to their follow-up schedule. Okay, instructions should be simple for these patients and repeated frequently with written information, so that the patient knows exactly what and when to report and where to go if they have any issues. The patient should also be encouraged to wear extra layers of clothing because a lot of them have cold intolerance. They should be warned not to use heating pads because a lot of them have diminished mental statuses, decreased sensitivity, and slow responses that may make them at higher risk for thermal burns. Practitioners are encouraged to write prescriptions for thyroid hormone replacement therapy that do not allow for substitution, and use the same medication brand for the patient throughout treatment to maintain consistency of dosing. So that's important. When you write the script, make sure you're keeping it consistent with the same brand so that your patient is getting a consistent dosing. The patient should definitely be taught the signs of iatrogenic hyperthyroidism or thyroid toxicity due to thyroid replacement overdosage. And remember, your thyroid replacement overdosage symptoms include nervousness, palpitations, insomnia, and tremors. Remember, it's important to explain to them that it will take 1 to 2 weeks for the medication to be effective. During that time, patients may actually experience an increase in urination and a decrease in periorbital puffiness because they're getting rid of it. Their body's getting rid of the hormones. I think that's it for that. Okay. All right, glandular disorders. So here we're talking about adrenal insufficiency. We have low levels of cortisol secretion by the adrenal glands, which can result in inadequate stimulation of the adrenals from the anterior pituitary, or because the adrenals are unable to produce adrenocortical hormones. Addison's disease, also known as primary adrenal insufficiency, is relatively rare and results from a failure of the adrenal glands to produce hormones because of a problem in the gland rather than a problem with the pituitary or ACTH production. Other types of adrenal insufficiency include hypocortisolism, which occurs from secondary sources, such as failure of the pituitary gland to produce adequate levels of the adrenal stimulating hormone, or the abrupt withdrawal of exogenously administered glucocorticoids, which previously suppressed endogenous adrenal hormone production. Addison's disease is primarily caused by the autoimmune destruction of the adrenal cortex in 80% of cases in the US. Although it can occur at any age, it most often occurs in people 30 to 60 years of age. And the prevalence of Addison's disease is 40 to 60 cases per 1 million persons in the US. Risk factors for Addison's include having a first or second degree relative with the disease. So genetically, if we have a patient with a family history of that, then we can definitely put that into our differentials. This again goes back to making sure you're doing your past social and medical history on your patient's family history on your patients. On your little genogram, that's something you would definitely want to include on a genogram. So in terms of adrenal insufficiency and educating your patient, any patient with Addison's disease or adrenal insufficiency needs to be well informed about the condition and the potential implications for a dysyncytin crisis if the patient should develop a serious infection or experience any other kind of physiological stressors. Given the significant risk from systemic illness, patients should be instructed to see their healthcare provider during the time of illness. So if they're having an active exacerbation, they need to see their provider. In these instances, additional corticosteroid or stress hormone supplementation may be required. For example, a doubling or tripling of the dose of hormone replacement therapy in the setting of an illness, surgery, or dental procedure. This may require IM or parenteral dosing, like intramuscular dosing, if oral supplementation is not possible. Thus, if possible, patients should be trained to self-administer IM injections and may be given a reserve prescription for parenteral hydrocortisone or similar agent to be used in these particular situations. So again, this is a disease they have to basically manage for the rest of their lives. And if they develop an infection or there's any major stress in their life, which very well could happen, especially with their comorbidities, leaving them immunocompromised, these are patients that you really want to have self-aware of when they need to act in terms of disease management. Okay, diabetes mellitus. So I'm not going to go crazy with this. We know a lot about diabetes. We've learned about it many times. We just want to definitely review it as part of this lecture because it's one of the definite common endocrine and metabolic complaints. Now, this is, diabetes is mellitus type 1 is a metabolic disorder, obviously characterized by severe insulin deficiency resulting from beta cell destruction, which produces hyperglycemia due to the altered metabolism of lipids, carbs, and proteins. This chronic hyperglycemia results in various damage to various body organs, especially eyes, kidneys, nerves, heart, and small and large vessels. Loss of vision, renal failure, loss of a lower extremity, chronic foot ulcers due to peripheral neuropathy are all common sequelae of long-term hyperglycemia. All of this, I'm sure you've all seen in practice. So that's type 1. Type 2 is characterized by an abnormal secretion of insulin, resistance to the action of insulin in target tissues, and or an inadequate response at the level of the insulin receptor. Keep in mind, type 2 diabetes reduces life expectancy because of complications that are affected by the duration of diabetes mellitus. the degree of blood glucose control, and other cardiovascular risk factors such as smoking and hypertension. And then, of course, because of these two, we also have to talk about hypoglycemia, which is a clinical syndrome of subnormal plasma glucose concentration that may affect infants through the elderly, although the primary etiology of the disorder differs markedly among various age groups. So we have adult hypoglycemia, which is less than 55, where we have a neonatal hypoglycemia, which is defined as a level below 30 in the first 24 hours of life. There is no universal agreement about hypoglycemia thresholds. However, with some research supporting a level of less than 50 for men, 45 for women, and 40 for infants and children. Regardless, clinical hypoglycemia occurs when the blood glucose level is low enough to cause signs or symptoms. Okay, metabolic disorders. We're going to get into obesity, upper obesity versus lower obesity. Obesity is defined as an excessive amount of adipose tissue or body fat. It is a chronic disease that is multifactorial and neurobehavioral in nature. The World Health Organization classifies obesity as one of the world's most neglected public health problems, and I totally agree with that. You are going to find that the majority of your patients have obesity or morbid obesity listed as one of their comorbidities, and it affects everything times 10. So make sure you are doing as much counseling and referrals and education as you can in terms of weight management, diet, and exercise. Obviously, like I just said, obesity is associated with multiple comorbidities, including an increased risk for cancer, cardiovascular disease, disability, diabetes, gallbladder, high blood pressure, osteoarthritis, sleep apnea, and cerebrovascular accidents. So the American Medical Association classified obesity as a disease actually just in 2013. And the US Centers for Disease Control, the CDC, bases its classifications of overweight and obesity on a body mass index, or BMI. Although it's not an entirely accurate reflection of increased bodily fat, the BMI produces a ballpark figure from which to estimate obesity. There is a table in your book, table 59.1, that gives you the calculating body mass index and classifies obesity. I have that table with me right in my practice at all times, so that when I'm assessing my patients, I do always include the BMI in my documentation. So again, we need to understand that there are two major types of obesity. There's upper body and lower body. I'm sorry, I wanted to just. So there's upper body and lower body. The two major types are central, which is apple-shaped, and lower body, which is pear-shaped. Patients with central obesity have excessive body fat in the abdomen and flank areas and are at greater risk for type 2 diabetes, coronary artery disease, stroke, and early death, compared with those with lower body obesity, and they have more tissue in the buttocks and thighs. So these patients with your central or upper obesity, those are your ones with a higher risk for diabetes and your long-term chronic diseases. So this is the one we really worry about. When I look at guys like this with the big belly and they're out shoveling snow, the first thing I always worry about is this guy's gonna have a heart attack. Okay, metabolic disorders, definitely wanna get into gout a little bit. Gout is a metabolic disease that produces an inflammatory arthritis. Gout was characterized as far back as the time of Hippocrates and has been referred to as the disease of kings because of its prevalence in the wealthy, who were able to afford the traditionally expensive purine-rich foods that typically trigger this disorder. Once a disabling chronic disease, current medical diagnostics and treatment modalities have decreased its disabling effects. However, I will tell you guys, this is a very painful disease. So things that you need to make sure is the goal of clinical management for this, for gout, is to terminate the acute attack. You want to prevent future attacks, terminate the current acute attack. You want to normalize your hyperuricemia and prevent potential complications of urate deposits. So management of your gout includes pharmacological treatment of the acute attack, as well as long-term medical and pharmacological treatment of hyperuricemia. Acute management of gout includes generalized rest, elevation and immobilization of affected joints, and pharmacological treatment. Prevention of disability due to gout is a reality today because of advances in pharmacological treatment. However, the patient has to become an active participant in the long-term treatment. This is so painful. This disorder, just so you know, the patient will present during an acute attack with pain, tenderness, erythema, and swelling of the affected joint. The typical presentation is excruciating pain that awakens the patient at night. It's usually described as throbbing, crushing, and pulsating. Often the patient can't even tolerate anything coming in contact with the affected joint. Even the bed clothing can be extremely painful. You want to do a really good medical history on this particular patient. You want to make sure they report any episode of recent trauma to the affected joint, a recent drinking binge, because keep in mind, alcohol can exacerbate gout attacks, an eating binge of gout triggering foods before the attack. These are things you definitely want to make sure that you are finding out, what triggered it. Okay, clinical pearls. So a couple of things I just want to make sure. We want to make sure we distinguish between chronic prostatitis and acute prostatitis. Remember, chronic is a gradual onset. Prostate can feel normal with the exam, versus the acute prostatitis presents as a sudden onset, and the prostate is swollen and very tender, and it's usually more common in younger men. Another thing I wanted to make sure we review is that SSRIs can cause erectile dysfunction in men, and the highest risk SSRI is Paxil. There are numerous drugs that can cause erectile dysfunction, including diuretics, ACE inhibitors, calcium channel blockers, beta blockers, like I said, SSRIs, benzodiazepines, and antihistamines. But Paxil definitely is your highest risk, so keep that in mind. Okay, so there is a quiz this week. It's in the module. It's part 2 quiz for renal. Please make sure it's going to be from this week and last week. So just make sure you review UTIs, both pyelonephritis, renal cancer, CKD and staging, AKI and staging, and pharmacological causes of erectile dysfunction. These are the things you make sure to review before you take your quiz this week. Thank you guys. I hope you have a great week. We will be posting a review on the coding quiz just so you guys can really go through that, make sure you're understanding it. Again, I can't stress enough, please watch the video that is posted, NP Real World, download her guide and just work as she guides you with her guide and see if you can really get a strong sense of how to code. All right, please, if you guys have any issues or concerns, do not hesitate to email me. We can set up a Zoom meeting. That's not a problem. I'm here to help you. I'm here to help make sure you guys succeed. And I want to see that you do the best you can do on your journey. So thanks and have a great week, guys.